I'm Joel Cohen. I practice in Colorado, in suburbs of Denver, and I see a lot of acne patients in my practice, and I'm also married to a pediatrician and the father of a young, almost 12-year-old girl. So I think that I've learned a lot from speaking to my wife and taking care of patients that are, in some cases, family friends or mutual patients of both of ours. We do a lot of maintenance regimens in our practice. So oftentimes we'll see people, and if they're not on a topical retinoid or topical BP agent, we'll start those types of things. But if people are really interested in trying to hopefully control a flare, then a lot of times we'll see them for something like a salicylic acid peel or a dermal infusion microderm system. And then those will be scheduled appointments about every 6 weeks. And if they perhaps flare or they're having a flare, then we can actually incorporate some other things along the way. So we do a lot of photopneumatic therapies for acne. We usually, if people have a flare, we schedule them for something. We have a Clera in our office. There's also Isolase. And the Clera allows us to see a patient and to get started on a regimen that uses IPL and photopneumatic. So there's an agent that actually causes suction, puts a little hole into the spot, and then helps relieve and decompress that area, as well as exposing it to appropriate wavelength of light that helps with some of the endogenous porphyrins. So people are interested in procedural-based treatments, and we have a lot of people who are on spironolactone and do quite well with it. But if people continue to flare, and that seems to be an issue, then they can continue those types of salicylic acid peels with or without the dermal infusion microderm system on a regular basis, and then do the photopneumatic for flares. But if they seem to be flaring a lot, if you get pushback about the discussion about Accutane and isotretinoin, then there are some alternatives that we incorporate. So we do photodynamic therapy for acne. There's a regimen that was published by Sakamoto and Rox Anderson a few years ago in JAD. And we do a modified regimen of that, but we apply the Levulin, and then we actually activate with red light, because the thought is deeper penetration. Sometimes we briefly use blue light just to sort of take care of things on the surface, and then go ahead and then penetrate deeper with the red light. So that's believed to get down to the sebaceous glandular activity. In some cases, we actually use a pulse dye laser as well to some of the very specific lesions after the Levulin is in place as well. So with those types of situations, people can get a lot of redness and a lot of swelling, but with a few treatments and understanding that there's going to be downtime, we do see a more durable improvement. And sometimes we know that kids are not that compliant with regimen, so if it's on a holiday or break, if you can get them to spend part of the break recuperating from a procedure like that, then we can see some more significant improvement. And we still want them to go ahead and use their topicals, but we're really just concerned about topical compliance. So the mainstay of what we do is still topical therapies. We have people on retinoids, we have people on topical benzoyl peroxide agents, we have people on combination agents, and we really just try to find a good balance. I think that as the adolescents we know are a little bit more challenging in terms of compliance, we can hopefully schedule those people in for some occasional peels. They do see improvement from the salicylic acid peels, and I think it helps re-engage them to remind them to use their topicals, and I think that helps. When it comes to some of the other devices that we use or modalities that we use, a lot of women, especially younger women who are in the workforce, who just really don't want to go through that perimenstrual type of flare and are having issues with that flare, we really try to get them on a good dosing regimen of spironolactone, but they're more apt to be interested in doing other types of treatments. So photopneumatic is very popular for them, as well as some of the adolescents. And then to get people to do something like red light PDT is a little bit more challenging. It's a smaller number of people who can actually take a week off or so to recover from a treatment like that, but they can see very nice improvement. But really the downtime is really one of the sticklers. I know that many people incorporate devices in their practice for the treatment of acne as well as the treatment of rosacea. And I think it's exciting to see that there's better and newer agents on the horizon. I know that there's some development of some photodynamic therapy products in Europe and overseas who hopefully will bring to market here, specifically looking at acne and more sebocentric. So that's really something that I think is exciting. And then the results that we see for post-inflammatory erythema, for acne, we use a device, the Lutronic laser, the Spectra laser, has a little gold handpiece that we can treat some post-inflammatory erythema. We use the pulse dye laser as well, the B-beam or the V-star for that type of procedure as well. So I think that we can see improvement in some of the post-inflammatory changes and post-inflammatory erythema of acne. And then we know from our experience with treating rosacea and type 1 rosacea, the people that have erythema and telangiectasias do quite well. And oftentimes we can get them to a durable improvement for many months if they avoid precipitants, warm beverages, spicy foods, alcohol, and a lot of flushing. Then we can see improvement for a long period of time. But some people just come in for maintenance treatments. My wife has type 1 rosacea, and sometimes we just go in on the weekend and do a pulse dye laser type of treatment just to sort of give her some balance and hopefully improvement